Good afternoon, everybody. Today's lecture it's going to be about blood banking and immune hematology, and maybe this is the most important lecture in immunology that you should know. Blood transfusion is so common all over the world, and physicians, they should understand the concepts of blood transfusion and immune hematology. So wherever there is a surgery, wherever you need to give blood to a patient for respective of the reason, the patient is having anemia, for example, or cytotoxic medications and so on, then you should understand here the concepts of blood transfusion and the immune hematology. So you should know that here we are giving living cells from one patient, we call him the donor or her, into another patient, we call her or him a recipient. And the job of the a blood bank is to assure safety. And we mean by safety that the patient should take the blood that is compatible with that particular recipient. If the blood is incompatible or given the wrong blood, then a reaction could take place and the patient could die as a sequel to that. So it's so important to give the blood to that particular specific patient, and this is what we call safety. And always, in order to be sure that the patient is taking the blood that is assigned for him or her, the patient has to be identified by what we call a double identifier. It's not just by the name, for example, and because names sometimes they could be similar. So how many patients you know their names are Muhammad, Ahmed, Mahmoud, for example? You could have 1,000 patients having the same name, but when you put another identifier, like for example the mother's name here, or the age as well, then you will minimize the mistakes that could happen. This is what we call double identifier. It's the major point that we follow in hospitals for safety. So we talked then again about how important to understand then blood transfusion need for surgery or chemotherapy or whatever here the need for a patient taking blood. And we talked about the safety. Remember the double identifier here point that always we keep talking about. And we say always that this is a we do have a sensitive test nowadays that we use in the blood bank to assure the safety and here the need for that particular blood to be taken. So always remember blood taken from a person, we call him the donor or her, to another patient, we call him or her the recipient. And we expect that sometimes complications could occur in the way. So we need always to balance here our needs. The need for the blood transfusion has to be balanced by the light of risks, and how dangerous the blood transfusion could be. So if it is more beneficial and very small or minor complications, risk is low, then we go ahead and we give blood. So in order to understand the blood transfusion theory, then you have to understand the structure of the red blood cells that we are here using for a transfusion. And you know, the ABO system is the most common one that we are using, as well as the RH here for grouping. And also you should know all the antigens that are present on the surface of red blood cells. And as you know from physiology, the ABO system is the most commonly used, and the Rhesus factor, RH here, but we are going to talk about many others that we call minor blood groups, and how those they have to be compatible to each other. So in the blood groups AB, and O system, the blood group antigens, the A and the B, at least here, those are carbohydrate antigens that are present on the surface of the cells, and they are carbohydrate antigens, as I said. Blood group A is N-acetylglucosamine, for example, and blood group B is a D-galactose. Blood group AB, you have both here together, and blood group O doesn't have these carbohydrate antigens, and those are located on a stem type of a molecule. We call it the H antigen. So the H antigen is the backbone, and then you have on top of those these carbohydrate antigens, and acetylglucosamine for blood group A, and the D-galactose for blood group B. So again, you have to understand then the physiology regarding the red blood cells and its structure. Carbohydrate antigens and acetylglucosamine, blood group A on the surface. The galactose here is the blood group B, and if you have both here, it's a blood group AB. If you don't have any of those, it's a blood group O. But you still have the backbone structure, which we call it the H antigen. This is really very important. Then blood group A, blood group B, blood group AB, and blood group O. So it's so important to understand this backbone antigen, or the H antigen, because in certain patients they could be missing here, and if the H antigen is missing, then more antibodies they are going to develop, because as you can see here, blood group A, you have anti-B antibodies usually are present. Blood group B, they are anti-A antibodies that are present. Blood group AB, you don't have neither antibodies, neither A or B. And blood group O, you have both antibodies, the anti-A and the anti-B. And as you can see, those we call them natural antibodies, the isoheme agglutinin, and they are IgM antibodies, so they do not cross the placenta. This is really very, very important to know. So blood group A has anti-B, blood group B has anti-A, blood group AB doesn't have neither antibodies, anti-A or anti-B, and blood group O, you have both antibodies, anti-A and anti-B. And as I said here, the backbone structure here for the H antigen, in certain patients it could be missing, and if this is missing, then that patient is going to have anti-A, anti-B, and anti-H. And this is what we call the Bombay blood group. Bombay blood group. And you can't give this blood, you can give it only to Bombay blood groups, because it has antibodies against the A and the B and the H as well at the same time. So this is very, very important to know. So the blood group antigens and the blood transfusion has been discovered at the beginning of the 20th century by a man. His name was Karl Landsteiner, and he's the one who classified the blood into groups, the A, B, and the A, B, and the O blood groups. Again, remember that blood group A, it's a carbohydrate antigen in acetylglucosamine, and blood group B is just the D-galactose, and AB has both, and we see those on the surface of red blood cells. Blood group O, you don't have any of those. AB have both. The ABO system is the most important here for blood transfusion. Very important to know. We have more than 600 antigens present on the surface of the red blood cells in about 207 forms. They form around, 23 blood groups almost. Each they are controlled by one gene, and then you could have alleles of these forms. So we'll say blood group A could have two alleles, A1 and A2. And the same thing for the B. You could have B1 and B2 of those, and the AB combination of those. So usually one is expressed, as I said, and detected in the blood bank. So they write on that blood group, for example, just a blood group A or blood group B, or blood group AB or blood group O, and if they have managed the subtype, identify the subtype, they say this is A1 or for A2, for example, or B1, B2, or just the A or the B, or combination of those. And other antigens, here the Rhesus factor, and in those the genes that will code for that is the C and D and E. So if they are capital, that means they are expressed, capital C, capital D, capital E, and the Rhesus factor here is the capital D. So the D antigen is the one that we look for in the blood banks, while the C and the E, it's just a phenotype that sometimes need to be identified for epidemiological purposes. So remember, is the capital D, or the presence of the antigen, here the D antigen is the Rhesus factor. So when we identify the blood group, whether it's A or B or AB or O, then we have to identify the Rhesus factor, whether it's positive or negative. A positive, A negative, B positive, B negative. Same thing for AB positive, AB negative, and for the O is the same. And the genetics for those, as you know, here as you have taken at high school, and the combination, usually Mendelian type of inheritance. Very, very important to remember that. So it's so important to know that in blood group A we have anti-B antibodies, blood group B we have anti-A antibodies, and in blood group AB we don't have any antibodies. Blood group O we have anti-A and anti-B all together. This is really very important here to remember. And also it's so important to know that the anti-A or the anti-B are IgM antibodies. That means they are pentamers, and if you give the wrong blood here group to the patient. For example, patient with the blood group A, and you gave him that patient to blood group B. Then the anti-B it's going to bind to the B. Here, as you can see, complement will be activated, and then destruction of the red blood cells are going to take place, and we call that here hemolysis. And this is how hemolysis is going to take place. Sometimes, of course, the isoheme agglutinins, they are IgM, as I said, and this is the most important in the incompatible blood transfusion. But sometimes, like in hemolytic disease of the newborn and so on, here where IgG antibodies could cross the placenta here and sensitize the red blood cells of the mother of Rh. If the mother, for example, is Rh negative, and she was pregnant with Rh positive baby. So the anti-Rh, the anti-D antibodies could cross the placenta and going into the baby and so on. And those antibodies sometimes they could bind, as I said, here into the mucosal surfaces here. So if you have, for example, blood group A here and given blood group B, so the anti-A could bind into here the tissues and sensitize those tissues, and then complement will be activated, and that tissue could be destroyed. So the most common then blood group, if you do statistics, is the blood group O. And this, for example, in Native Americans, around 79% of the people there they are here blood group O. And the same thing here when you talk about Asian, for example, communities, around 40% of people, they are blood group O, and then followed by blood group A, and then a blood group B, and the rarest one is the blood group AB. So blood group O is the most common among all of the blood groups in general, and the rarest of those is the AB blood group. This is very important to remember. So in summary then, the blood groups are carbohydrate moieties. Their specificities reside in the terminal sugars. Remember that on the surface of red blood cells present, those, as well as on the endothelial surfaces as well. And if the patient is secretor or non-secretor, then you are going to have those in body fluids, and this is important if the patient is secretor, important for here epidemiological purposes. We have a transferase enzyme that conjugates the terminal sugars to the carbohydrate stem, and this is the stem is the H antigen that those, as I said, carbohydrate antigens bind to. So the H antigen then under the influence of fucosyl transferase, for example, if it doesn't have any of those, we call it a small h, the OH, or what we call a Bombay blood groups. So if you don't have the carbohydrate antigens and you have a patient without those carbohydrate antigens at all, I mean, if that patient doesn't have the carbohydrate antigens, then it's a blood group O. But if the patient lacks the stem here sugar, which is the H antigen, for then the patient is going to have anti-A, anti-B, and anti-H at the same time, and this is very dangerous. As we said, we call it the Bombay blood group. So we could have anti-H antibodies. That's going, that patient cannot take blood at all from any human being other than a Bombay blood group, the same thing. So remember, the N-acetyl glucosamine is blood group A, and the D-galactose is blood group B, and both we have blood group AB. And then we have subtypes like A1, A2, and B1, B2, for example. Anti-A and anti-B, here are natural antibodies, as we said. We get them from exposure to microorganisms in the gut usually. And we have what we call Lewis and secretor, that if you have the capital S, that means you are secretor, then you could secrete those in body fluids. S, capital letter, secretor. Small s, non-secretor. So the significance then in having the subgroups 1 and 2, for example, is for forensic investigation. And seeing a body fluid in the scene of the crime, you can tell the blood group from the body fluids of that particular victim, for example. So again, the Rhesus factor, or the D antigen, as I said, here could be present on top of the backbone here, where the carbohydrate antigens are located, and those either, as I said, the C or D or E, and only D that is so important. So if it is capital C, that means C is expressed, capital E, E is expressed, and capital D, that means it is Rh positive, while the capital E and the capital C, those are just phenotypes, but they are not that important here in medicine, other than for epidemiological purposes. But the capital D is the most important. Capital D, that means it is Rh positive. But the others, for example, you could use them in the nomenclature. Here, when we talk about capital D or Rh positive, if the R, for example, is capital, we call it R1. If it has the E, for example, we call it R2, and so on. Here we could use that for epidemiological purposes. So in this slide, as you can see, the capital R, for example, indicates that the patient is having the Rhesus factor, which is the D antigen. Small r, absence of the antigen, and so on. The capital E, small e, here refers for epidemiological investigations for the body fluids, and the here the antigens here for the blood group antigens that could be present in that body fluid, whether this patient is having an Rh positive or Rh negative, and whether he or she is having the capital D or a capital C or capital E. The most important one, as I said, is the capital D here. That means it has the Rhesus factor. Capital E and capital C is not that important. It's just for epidemiological purposes or different phenotypes. So the Rhesus factor is extremely important in the diagnosis of the hemolytic disease of the newborn, especially here when the mother is Rh negative and the baby is Rh positive. This is going to be responsible for what we call delayed here hemolytic transfusion reactions, and the baby is going to be born with what we call jaundice or hemolytic blood. So when we talk about these, the genetics of the rhesus factor is the presence of the capital D, but the capital C or the capital E, they are not that important, only, as I said, for epidemiological purposes. So R capital, H capital, D capital, the presence of D here, and RH capital C, capital E, that means those are present as well. So RH capital D codes for the D polypeptide, and it's completely absent in the Rh negative individuals. So the capital D is the most important. RH capital C, capital E codes for C and E here proteins. Either they are present or absent. Different nomenclatures, sometimes based on the genetics, whether you have capital C or capital E with those or not, then we call it a different name. But the capital D is the most important. So again, then the nomenclature, then it depends on the presence of the C and the E beside the D here. Capital D, it means Rh positive, small d, Rh negative. So here we have, for example, the Wiener classification. It depends on capital R, for example, here. Capital R, it means Rh positive, it has capital D in it. Or مثلا RHO, rho, you call it. That means it has the capital D with it. Small r, it doesn't have it, تكون Rh negative allele. So the absence تكون small r, the capital R presence, or rho they call it. The Fisher, for example, and Rhesus, the capital D, capital C, for example, small c, capital E, and small e. Capital D بسموها rho, capital C بسموها RH comma, but it doesn't have the rhesus factor here with the capital C or capital E. So the most important thing is the capital D. Those usually are inherited as two sets, one set from the father and one set from the mother, as a group of three from each parent. You have to know that around 85% here of people in the population are Rh positive. That means they have the capital D here, and 15% usually are negative, Rh negative. And some they are homozygous or heterozygous. Here, very important to know. And heterozygous sometimes become strong or weak. Here, if you have two genes strong, one gene weak, but it's still positive. So sometimes the testing here, it depends whether the patient is heterozygous or homozygous, and here we use what we call the antiglobulin test for identification. If it is weak, for example, we put the anti-D antibody, and then we detect that with a secondary antibody against the primary antibody. So here, if it binds to the weak antigen, it will give a positive results and becomes Rh positive. So whether it's weak or not, as long as it has the capital D, it is Rh positive. So in general, we have more than 20 blood groups, 20 blood group systems here, and rarely involved in transfusion. And the most important thing in blood transfusion is the ABO system and the RH. Those are the ones that we identify. Then we do here what we call cross match. We'll talk about it in just a second. We have other minor blood groups, like one we call it the KID, one we call it Duffy, one we call it the KIL, MNS, for example, and those they can cause hemolytic type of reactions if they are not compatible, and usually antibodies, as I said, of the IgG type rather than of the IgM type, that's going to bind and associated with minor hemolysis if they are compatible with the minor blood groups. So anti-KID, for example, as a blood group, can cause a delayed hemolytic transfusion reactions, like in hemolytic disease of the newborn, for example. And this is sometimes difficult to detect when you have here jaundice and you don't know here what causes the hemolysis. So you have to look for these minor blood groups. So their genetics, whether, for example, JK, and they have the A plus, B minus genes, or the JK, for example, A minus, B plus. And here the JK, both that they are plus, or the JK, they are both negative. The Duffy blood group, FYA and the FYB, and those, for example, the codominant together, that they are inherited. FYA usually more associated with delayed hemolytic reactions. In the Duffy blood group, here, if it is positive, it is the receptor for the Plasmodium vivax malaria. This is so important to know. So the Duffy blood group is a minor blood group antigen where the Plasmodium binds into it, and so the patient becomes susceptible of being infected with malaria. We have the KIL blood group, capital K, and small k, that means it doesn't have the KIL blood group here, which is more frequent. And this one is associated with delayed hemolytic reactions as well. We have the macloid, also minor blood group, phenotype. Here, if the patient lacks that, K X, for example, small x on the surface of red blood cells, and could be associated with a neuromuscular abnormalities in those patients. Could be associated with the chronic granulomatous type of a disease, for example. So the genetics of the minor blood groups, there is an association with the chronic diseases that sometimes it's so important to know. Yeah, this is a typical case of the hemolytic disease of the newborn when an Rh negative mother is getting pregnant with an Rh positive baby. Usually during the first delivery, here some of the Rh positive red blood cells could sensitize the mother, and so in the next coming pregnancy, here the anti-Rh positive antibodies, they will cross the placenta going to the baby, and complement will be activated, and then here the red blood cells of the baby are going to be hemolyzed, and we call that hemolytic disease of the newborn. And these antibodies, they are IgG antibodies because they have to cross the placenta, while the IgM antibodies, they do not cross. So they are not isoheme agglutinins here, or I mean like an anti-A or anti-B. No, they are here anti-RH, here antibodies that they could cross the placenta going to the baby and then hemolyze the red blood cells of the baby. So in order to prevent or to treat that condition, we have to do what we call exchange transfusion. That means that the baby that is undergoing hemolysis, we exchange that blood of the baby and replace that with Rh negative blood, usually O negative blood. So we replace the whole blood with Rh negative O blood, and that's it. This is how we treat that condition. And then later, to prevent that from happening, usually the minute that we know that the mother is pregnant with an Rh positive baby, we give that mother high dose of what we call ROGAM, which is antibodies, anti-H antibodies. So here, if any red blood cells here could escape here during delivery, then they will be neutralized by this anti-D antibodies. So it is so important to understand that if the mother, if an Rh negative mother get pregnant with an Rh positive baby, then the second delivery, the mother could have here what we call hemolytic disease of the newborn. So it's extremely important to know this fact, and these are some of the emergencies in medicine that you should know. So in the hemolytic disease of the newborn, the way we make the diagnosis is through a test. We call it the Coombs test. And in the Coombs test, we have two types, either the direct Coombs test here or the indirect Coombs test. In the direct Coombs test, we detect the sensitized red blood cells that they come from here the mother into the circulation here during a pregnancy. So we take here some red blood cells of the baby that could be sensitized here. These are the red blood cells and sensitized with the anti-D antibodies. And then we add what we call the Coombs reagent. The Coombs reagent is anti-human globulin, is antibodies against human IgG antibodies. And so clumping will take place. So that means it is positive. That means the baby has the sensitized red blood cells, and here requires to have the anti-D antibodies. And we want to see if the mother is sensitized. That means she has antibodies here against, or anti-D antibodies or not, and she developed anti-D antibodies. What do we do? We get an Rh positive red blood cells here, and then we add anti-D antibodies. So we sensitize those. I mean, those are red blood cells Rh positive. We get the mother's serum here, and then you sensitize the Rh positive red blood cells. So now they become sensitized. These are the antibodies that usually we get from the mother, and these are the Rh positive cells, so they become sensitized, and they come from the mother, I mean, and those are the ones that we get from the lab, Rh positive cells. So now we sensitize the Rh positive cells with the blood of the lady, and then we add the antiglobulin reagent. So clumping is going to take place. That proves that the mother is having antibodies against the D antigen, and she got sensitized. So immediately we have to give the anti-D reagent here before pregnancy, before delivery, I mean. So the methods for detection of antigen and antibodies to erythrocytes, we call it the Coombs reagent, as we said, or the antiglobulin test. Already, if the red blood cells are sensitized, we detect them, or if the mother has antibodies, also we could detect them with the indirect antiglobulin test. So in the direct, then, here we detect antibodies or even complement on the surface of the red blood cells. We call it the DAT, or direct antiglobulin test. And sometimes you could have autoimmune diseases, for example, where antibodies are attached to the surface of red blood cells, or sometimes drug-induced hemolytic anemias here. So you could have antibodies bound to these drugs, as well as with the hemolytic disease of the newborn, hemolytic here transfusion reactions. Or in the indirect Coombs, we detect the antibodies, not the, and we sensitize them in vitro. So we detect antibodies in serum or plasma, indirect antiglobulin test. So we get the serum or plasma. They do have antibodies that can attach in vitro, and we make the attachment or sensitization in vitro to red blood cells. Then we add the antiglobulin reagent. So the indirect here antiglobulin test here, we ID the presence in the indirect antiglobulin test. We identify the presence and the specificity of here recipient plasma antibodies. So we use it here to detect the antibodies. We select the donor blood here free of specific red blood cells, antigens here. Then we confirm the absence of antigen antibody reaction recipient plasma here against the donor red blood cell, and we call that a cross match. So the antiglobulin reagent, we add it here after we add the antibody, and we make the sensitization in vitro, as simple as that. So then before a transfusion, then we do what we call the pre-transfusion testing, or type and screen. And this method that we do in the blood bank, the goals of that is to prevent here the destruction of the transfused red blood cells, as simple as that. So the recipient, we do the ABO, blood group antigen, and the RH at the same time, and blood group and the RH antibodies to red blood cell antigens, and the type and screen. Then we add the antibodies against the red blood cell antigens. This is what we call type and screen. So the recipient now plasma is tested against here the donor red blood cells, and this is what we call the cross match. So if I ask you what do we mean by the cross match, it just simply we go to the recipient blood, we take the plasma, recipient plasma, and which is supposed to have antibodies, and then we add on those the donors red blood cells. So this is what we call the cross match, to see if a clumping is going to take place or not. So the type then and screen is the recipient now blood typing, the recipient, and we do blood grouping at RH. Recipient plasma is screened. We call that the cross match, as I said. So remember that what do we mean by the cross match? Another name for it is the immediate spin technique. So the cross match, then simply here is the recipient plasma. We add on those the donor red blood cell. We spin them عشان هيك بنسميه هذا immediate spin technique, and we see if and then we add the antiglobulin reagent, and we see if clumping has taken place or not. So this is what we call the cross match: recipient plasma and the red blood cells of the donor. This is very, very important to know. So for transfusion then reactions, we could have hemolytic reactions when red blood cells they are destroyed, or non-hemolytic. That's usually is related to the cytokines that are present. So here, as you can see here, in the causes for the transfusion types of reaction could be due to the erythrocyte antibodies here, and then hemolysis, or for example hemolytic or non-hemolytic, as I said. And here, as you can see, the here the incidence is so low, because usually those patients or specimens are tested. So rarely you could see that in 0.02%. So the manifestations we see is fever, chills, and then the blood pressure will go down, hypotension, and sometimes we see back pain in the back here, or at the infusion site, and hemoglobin, we check the hemoglobin. Sometimes we see hemoglobin in blood as with the urine because of the rupture of red blood cells. What do we have to do in this case? We have to stop the transfusion immediately, and we have to take blood specimens and urine specimens as well, and then we have to hydrate to dilute the blood as much as possible, and then we keep monitoring here the hematocrit level, for example urine, and we see if the hemolysis is still going on or not. And sometimes طبعا هذول we notice that the hematocrit will keep lowering, getting down lower the hematocrit, and then we increase the bilirubin level, the enzymes, the LDH, lactic acid dehydrogenase here, and takes usually days, 2 weeks here post transfusion. So we have to monitor those the same thing, and to check for the kidney function tests as well. The other ones here, when we have the cytolytic white blood cells, sometimes could be responsible for that. The cytokines that are produced responsible for the fever, although we see them in about تقريبا less than 2% of cases, and we monitor the temperature for those. Usually it will be raised more than 1 degrees centigrade, and sometimes they could have chills. And the same thing here, we have to stop the transfusion, and in all cases we have to stop the transfusion, whether it is hemolytic or non-hemolytic, here, in order to investigate what is the real cause of the hemolysis or the increase in body temperature and fever and so on. And then here we stop the transfusion, and then we rule out the hemolytic reactions by checking the hematocrit continuously, and check the urine for any blood, for example, or hemoglobin in the urine. And sometimes we use antibiotics on those patients if the temperature is high. But the most important thing is to know what's really causing the symptoms of the patient who is taking the blood. Sometimes the cause is the donor white blood cell antibodies sometimes, and then against the white blood cells, and then rupture of the white blood cells, and we see that in less than 0.2%. And usually non-cardiac pulmonary edema, sometimes you could see that, and bronchospasm. And the same thing, we have to stop here the transfusion and treat the symptoms. And finally, here sometimes if the reaction is related to the plasma proteins, and we see that in about 2 to 3% of cases. In this case, the patient usually is having itching, and we can do allergies against the foreign plasma. Here, itching, urticaria. This is so important clinically for patients, for physicians to know. And if the patient starts itching and so on, that means develop allergies to the foreign plasma. Rarely develops asthma, for example. Could develop bronchospasm, and rarely develops anaphylaxis. And in any way, we have to stop the transfusion, and we have to give antihistamines for those, and sometimes steroids for the urticaria, and we treat the symptoms. So this is a clinical case, talks about a 48-year-old man who underwent blood transfusion, and if you read the case carefully, you will see that this patient was given a blood of another patient who has the same name, Muhammad Ahmed Mahmoud مثلا, and the same thing without checking here the double identifier that I was telling you about. So then when he took the wrong blood, like for example, he has antibodies against the blood group B, blood group A, anti-B, and he has blood group B, so antibodies bound to the antigen, and hemolysis was taken place. So anybody who is taking blood, they have to be washed and monitored thoroughly for any signs of mismatch blood or incompatible blood transfusion. Increased body temperature is very, very important. And the first action when you see any signs and symptoms is to stop the blood transfusion immediately. Then you have to monitor the patient taking, as I said, urine specimens and look for hemoglobin. And then after that, hydrate as soon as possible, and show for the signs of the systemic inflammatory syndrome, where massive blood transfusion, massive red blood cell hemolysis was taken place. And then when you hydrate and stop the blood transfusion, usually the patient will improve. And if you have to give blood, you have to order O negative blood is the best to do that. But here, stopping the blood hydration with normal saline usually improves the case dramatically. So here, when we talk about many cases of incompatible blood transfusion, that usually has to do here with safety measures was not taken properly, especially here when the names are similar in the hospital. Very, very important to know this. Read this case carefully and see how they have managed this case. So in summary, then, the blood transfusion reactions here, they could be either immediate or delayed. The immediate, usually they occur within minutes, maximum to an hour or two, and here the immediate hemolytic reactions is usually fatal if was not taken a proper action. And this is the one that is usually related to managerial or clerical error. Any patients here with a similar name, and they took incompatible blood. Took other blood groups. He was blood group A, so he took blood group B that has anti-A antibodies, and then complement is activated and hemolysis of red blood cells starts taking place. Patients usually complain of fever with chills, chest pain, hypotension, blood pressure goes down, nausea, flushing, here dyspnea, cannot breathe, and hemoglobin that you can detect in urine. And sometimes they develop shock, disseminated intravascular coagulopathy, and sometimes renal failure because of the hemolysis or renal shutdown, we call it. This is in the immediate type that occurs immediately following taking the incompatible blood transfusion. The delayed type usually takes place after 3 to 10 days after the transfusion here. Usually the patient is previously sensitized. The person failed here to detect the antibodies, so it takes time to detect those. So the patient will develop fever, gradual, and then anemia, and also jaundice. And then we do the direct antiglobulin test, and then we do an elution, what's like washing the red blood cells and getting the antibodies on those. And then we do the indirect antiglobulin test on those. And usually this is not fatal. So the delayed, nothing compared to the immediate type. So here the second type is the febrile non-hemolytic types of a reaction. Patients develop fever, but when you check the hemoglobin, usually there is no loss of hemoglobin, and usually this is related here to antibodies directed against the white blood cells. So the white blood cells usually get destroyed, and the cytokines are responsible for the fever. And these cytokines are usually the interleukin 1, you know them, the cytokines of inflammation, interleukin 1 beta or interleukin 6, tumor necrosis factor alpha, and sometimes those they could be produced during storage, and so that's why the stored blood has a limit in blood banks. It shouldn't exceed that, otherwise patients could develop febrile non-hemolytic types of reaction. Second thing, we have to distinguish from fever of hemolytic reactions, and here simply you have to check for the hemoglobin and see if hemoglobin is getting down. That means the patient is having hemolysis. If the hemoglobin is solid, that means there is no loss, then it is febrile non-hemolytic types of reactions. And also we have to distinguish it from fever of infection. So you have to rule out any infectious process, especially with bacteria, and by culturing the blood and check for any elements of the presence of bacteria. This is extremely important to differentiate, because infection sometimes, especially with the gram-negative bacteria, causes sepsis and death. Also, we have to control that with antipyretics, and give antipyretic medications, and sometimes we could give white blood cell reduced blood units, and we could be using filters here to filter the white blood cells from the donated blood. And we filter the components from any white blood cells. Or recently collected components, so they will not produce these cytokines. So a transfusion related acute lung injury sometimes could take place. So here it happens when you have anti-leukocyte antibodies, and this could be responsible for here pulmonary edema that could take place in the recipient. So here usually the cause of this acute lung injury is the donor antibodies. They bind to recipient here granulocytes. Complement will be activated, and the leukocytes will be damaged, and their enzymes they will be free, causing the lung damage. Free radicals, for example. So the destruction here of the leukocytes would be responsible for this. So the patient is going to have fever, dyspnea, shortness of breath, and marked hypoxemia. So the PO2 will be so low. And usually occurs 1 to 6 hours after, and the risk is minimal here because there is no massive here hemolysis taken place here. Anything related to white blood cells usually is serious, but it's not fatal. Sometimes patients could develop an allergic type of reactions when they take a blood unit. So they develop itching, for example, they were a flare type of reaction, local erythema sometimes, and usually it is caused by the infused plasma proteins. And the plasma proteins that was given to the patient who took them is usually allergic to them. So they usually are associated with a history of allergy. And that particular patient that we took his blood units has a history of allergic conditions, or sometimes the recipient could have a history of allergy as well. So we treat with antihistamines, very important. We give corticosteroids as well for treatment of any allergies. We could use here washed red blood cells in severe types of reactions to minimize the reaction. Also, we could use a plasma protein deficient patients, like, for example, remove the IgA antibodies if they are allergic to IgA antibodies, for example. Or patient here could have bacterial contamination, so we have to treat with antibiotics and to do cultures at the same time. Or sometimes you could have other causes, like for example, if the unit is stored in inappropriate place, so overheating and hemolysis has been taken place, or freezing sometimes, or mixing with isotonic solutions caused hemolysis. Sometimes this could cause these types of allergic types of reactions. So here sometimes we could have what we call transfusion transmitted infections. That means the recipient blood could be contaminated, and most of those are contaminated with viruses. And hepatitis C is the most common virus that could here cause the post-transfusion hepatitis C. And one in every 103,000 here blood transfusions we could have hepatitis C. And hepatitis B as well, here serum hepatitis, the same thing here. This is also common. Usually before giving any blood transfusion, we take history from the donor. Any history of jaundice, for example, here for the last year or so, usually we don't take blood from that here, or any history of previous blood transfusion. So we take a good history here to rule out any hepatitis, whether hepatitis C or hepatitis B. Also, the HTLV1 and 2 those they could be transmitted also by blood. And of course, the HIV virus. The HIV virus could be transmitted also by blood, and here those they have to be tested at least routinely for hepatitis B, C, and HIV. This is very common, and also for treponema pallidum and syphilis. Very important to they have a battery of tests to do on the donor, and any of those, if he or she shows that positive, they don't take blood from those patients. So remember then the hepatitis C and B and HIV. Here, those are the common viruses that we look for: HIV, C and B, and others. Here the so again, in summary, then the transfusion transmitted infections, and infections that are transmitted from the donor blood. There are so many, as I said, but few of those that can be detected usually by routine screening. Remember the hepatitis C and the hepatitis B. Bacterial contamination here it's a possibility, and the hepatitis C and B, as I said, cytomegalovirus, and the HIV virus, very important to monitor in those patients. And of course the HTLV 1 and 2 can be screened also for. So in order not to be infected with those infectious agents, you have to take a proper medical history, especially history of jaundice, as I said here, and we should follow a complete aseptic blood collection technique, so not be infected with bacteria. Adequate laboratory testing, like for example the hepatitis B surface antigen and the anti-hepatitis B C here antibodies. The anti-C, by the way, here for the anti-C for the hepatitis B is the first antibody to be shown, so we have to use that in the blood banking as well. The hepatitis C virus, the anti-HIV 1 and 2. Also, we can use the HIV P24 antigen. Easily we can use that for to detect here if the patient is infected with HIV or not. Anti HTLV 1 and 2 viruses, and we can do serological test for syphilis and see if the patient is infected with treponema pallidum or not. Usually post-transfusion hepatitis is extremely rare when we do these tests, and it's less than 1%, and 95% is usually the hepatitis C virus, as I said, followed by the hepatitis B, which is 5%, and 50% usually of those are associated with chronic hepatitis. And 10% of those could lead to cirrhosis of the liver. Usually, some infectious agents infected here from the white blood cells, like the cytomegalovirus here, and 50% of donors usually are infected here with the cytomegalovirus. So here, if we So our target is to have 100% seronegative blood. But at least even if those patients, 50% of patients can be infected and they recover, but in spite of that, we have to take here no risk or chances. Especially here if patients are given to low birth weight infants. Those are usually vulnerable and they are immune compromised. Pregnant women, pregnancy, you consider it as an immune compromised as well. And the patients who are undertaking bone marrow transfusion, for example, here, or any organ here transplantation, here we have to take care of those because those they usually are under immune suppressive medications in general. What about transfusion transmitted infections, any other infections besides the ones that we have talked about? We will concentrate on the HIV. This is extremely important to monitor and to screen for HIV. HIV can be transmitted by any blood component. Even if a patient is taking fresh frozen plasma or platelets, could be infected with the HIV virus. 1 to 675,000 here per units of blood that are transfused could be infected. So as you can see, the number is so minimal because of these tests that we do in the lab. Very important to remember here what we call the window period, that sometimes it takes time for those patients who are infected with the HIV virus, especially here, to develop antibodies to know that they are infected here. So we call them, we call that the window period. So we have to do more sensitive tests, especially take proper history here to be sure that the patient is not infected with the HIV virus. So remember the window period, that the patient is infected but doesn't have any antibodies to show, and usually is not positive. The antibodies that we monitor in those HIV patients are for HIV-1 and HIV-2 and the P24, as I said. Also, the patients who have HTLV 1 and 2, those they could develop what we call tropical spastic paraparesis disease. Sometimes HTLV associated myelopathy, also TSP HAM here could be associated with these types of viruses. And also patients that have what we call adult T cell leukemias, here they could develop their gallbladder here, and kidneys could be affected. Other diseases that can be here transmitted by blood transfusion, like sometimes bacterial contamination from the skin, for example, or the donor skin. In Sanhek, we have always to have a complete aseptic technique. Second thing here, the refrigerator temperature has to be checked in those blood banks versus, for example, the room temperature. The blood units has to be stored in special refrigerators. They should not be kept at room temperature. This is very important to know. The mortality rate here as when patient is having gram-negative sepsis, for example, is extremely high. And 25% of those patients, if the blood is contaminated with the gram-negative bacteria, they will die. They develop gram-negative septicemia or septic shock, and they die. What about the Epstein-Barr virus that causes infectious mononucleosis syndrome? Yes, could be transmitted by blood that you should monitor as well. Syphilis, although it is extremely rare, but could be transmitted here by blood transfusion. طبعا especially here not from a refrigerator, because the Treponema pallidum is extremely sensitive to cold. So if the blood is in the refrigerator, it's extremely rare that this could be transmitted to humans. What about malaria or babesia, here macrotii, or Trypanosoma cruzi, or Vaccaria bancroftii, or loa, here the filarial worms, and even leishmaniasis can be transmitted by a blood transfusion. So you have to remember that not just viruses like hepatitis C or hepatitis B, HIV, but also here parasites like the malaria. If the blood was taken from a patient who has malaria and you give it to another patient, yes, that patient could develop malaria, or even other worms, filarial worms as well. Here they have to be taken in consideration, or even the leishmanias. So in the transfusion reaction, some of the immunological mechanisms here that is taken place is usually the antigen-antibody complexes that will develop on the surface of red blood cells. And we could see that on the membrane of those cells. Hagman factor, for example, here, which is factor 12A, will be activated, complement as well. The cytokines will be released, the cannon, like bradykinin, which lead to hypotension, that sometimes here patient blood pressure will fall down following these types of reaction. The complement and the leads to hemolysis, of course, histamine that are produced from mast cells as a complication here, and of course clotting, sometimes cascade, could lead to disseminated intravascular coagulopathy and death. The transfusion associated graft versus host disease, that sometimes the patient or the donor lymphocytes are given to recipient, and those lymphocytes could cause damage to the tissue of the recipient. We call that graft versus host disease. So we have to get rid of these lymphocytes from the donor by radiation of the blood. So we'll prevent that from taking place. Remember, graft versus host reaction. We talked about the hemolytic disease of the newborn. Just we will summarize that again, or what we call the RH isoimmunization. Here, when we have the de-immunization, the RH positive, usually it depends on the dose, how much RH positive blood oozes from the mother to the baby here. Usually the IgM antibodies started, then it will be followed by IgG. Usually the IgG crosses the placenta, while IgM does not cross the placenta. So usually the mother has to be Rh negative here. And then it will develop here antibodies against the Rh positive red blood cells. So the fetal Rh positive cells here going into Rh negative mother. This is the isoimmunization. So the anti-D antibody, which is usually IgG antibodies, they can cross the placenta and going to the baby, causing hemolysis of the baby's red blood cells. Usually it's so if, for example, for any reason, the mother had transplacental hemorrhage, for example, she could be sensitized, or if she developed antepartum hemorrhage as well, or she had what we call toxemia here, or cesarean section, or manual removal of the placenta, she could be sensitized. Abortion, for example, rough abortion, for example, and here amniocentesis, for example. This is a procedure here where they could take a specimen from the amniotic sac, or chorionic villus sampling, taking a sample here through the placenta, sometimes could make desensitization. Or percutaneous, for example, umbilical cord sampling, we could lead to sensitization. So we have to do then prophylaxis, Rh prophylaxis for the hemolytic disease of the newborn. And the way we do that is by we give a very high titer of Rh immunoglobulins. We give 300 microgram within 72 hours. This is going to cause a negative feedback. We call it a negative modulation of the primary immune response, and it causes negative effect here, and negative modulation that will suppress the production of these antibodies. How it is given? Usually we give it at 28 weeks of gestation, and then after that, after any invasive procedure, then we have to give the anti-D antibodies. But it's so important to know that here, if the indirect antiglobulin test is positive, that means that the mother is already sensitized and has antibodies, then the Rh immunoglobulin is not effective anymore. And if she already developed the antibodies, then this is not going to be effective. So the idea is to give the ROGAM, or the immunoglobulins here, so she will not develop antibodies that will go to the baby. This is extremely important to know. If the antibodies are already there, then it will not be effective. Here, sometimes we might not need to give whole blood. So sometimes we could give what we call component therapy. Like, for example, we could give just only red blood cells. We call it packed cell volume. And usually here we need to give that just to increase the hemoglobin level, to increase the hemoglobin capacity unit. So you can see, for example, if the hemoglobin is more than 10 gram per deciliter, usually we don't need to do anything. This is okay. And if the hemoglobin is less than 7 here gram per deciliter, then transfusion is useful and it is indicated. And if the hemoglobin is between 7 and 10 gram per deciliter, we have to assess the clinical status, and we could use a mixed venous PO2 and oxygen here extraction ratio. So it depends then on the clinical condition of the patient. Or we could give platelets, and this is so common in patients. We use to control or prevent bleeding due to low platelet count or in abnormal platelet function. And one concentrate here of platelets increasing the platelet count by approximately 5,000 platelets per microliter. Generally, platelets with platelet count less than 50,000 or between 10 to here 50,000 here should receive a platelet here to prevent bleeding. Otherwise, patient will bleed. Actively bleeding patient with platelet count less than 50,000 may benefit from a platelet. So sometimes we need just to give platelets. We call it just one concentrate. And we could use what we call fresh frozen plasma. And the fresh frozen plasma, here we use it to give clotting factors, for example, if there is a bleeding going on. It's used to increase the clotting factor in patients with documented deficiencies. If, for example, the prothrombin time is more than 1.5 in normal, and the 1 unit usually increases the level of any factor, usually 2 to 3 times. So fresh frozen plasma should not be used as a volume expander, like normal saline, for example. So we shouldn't be using the fresh frozen plasma for that. And the fresh frozen plasma is useful for the treatment of certain factor deficiencies, like factor 2, factor 5, factor 7, factor 10, 11, or factor 12, for example. So factor deficiencies, we have to use fresh frozen plasma. And also it's very effective if the patient is having an overdose here of if the patient is over treated, for example, having here over treating bleeding here, or whom require, for example, emergency surgery, for example, or can be useful in massive here blood, for example, a transfusion, for example, if it is more than 1 blood volume within a few hours, for example, like an emergency. And finally, fresh frozen plasma is useful as a source of C1 esterase inhibitor. If you remember that, if that is missing, the patient is going to have here angioneurotic edema. So we could use fresh frozen plasma to compensate for that factor in deficient patients with life-threatening here angioneurotic edema, I said, and in patients with thrombotic thrombocytopenic purpura, for example. So again, we just certain concepts related to blood component therapy. As I said here, if we need to use only erythrocytes, the one that we call packed cell volume, usually a 20% loss of blood. Here, for example, we use an electrolyte solution alone, then supplemented with a protein solution. If the loss is between here 1 liter to 1.2 liters, for example, loss in surgery, here no need for whole blood. Maybe just red blood cells may be needed. One packed cell volume will be needed. Here in a chronic anemia, for example, versus acute anemia. In acute anemia, I think we need here to replace blood and to increase the here the hematocrit level. While in a chronic anemia, sometimes the body is adjusted, and here maybe the interference will be much less. It depends on the evaluation of the clinical case. Sometimes we could be using here what we call blood filters. Here sometimes we could use those, as I said, to get rid of certain lymphocytes or other cells sometimes. Again, the summary for the platelets use here, whether it is quantitative or qualitative. When the number of platelets or their efficiency that they are not working, both cases. Or, for example, if they are the production of the platelets is compromised, then we have to use that. For example, pooling or dilution here of platelets, then we have to use platelets. We use what we call platelet concentrate, as I said, or here platelet pheresis, and separate the platelets and then we can give it to patients. We use what we call platelets concentrate, and one concentrate usually increases the platelets number from around 1,000 to 10,000 per microliter. And also here the stable, for example, febrile thrombocytopenia in adults. We could use that. We call it stable here afebrile thrombocytopenic purpura, usually in adults. So we have to use these concentrates. And if the count in general is less than here 10,000 per microliter, do you know that the number should be over 400,000? If the number is less than 50,000 per microliter, here we could have brain, eye, or spinal cord bleeding. So we have to use here platelet concentrates. Also, we could be using plasma products, like, for example, fresh frozen plasma, as we said, and sometimes stored plasma as well. We call that cryoprecipitated. And here it's usually the source of coagulation factors. If they are missing, for example, we can use that. Also, they are the source of coagulation factors in general, like factor 5 and factor, for example, here 7 are very high in fresh frozen plasma, so we could compensate their loss. What we call cryoprecipitated, for example, for factor here 7 and the von Willebrand's factor, for example. So we could use that. Used if fibrinogen, for example, is less than 100 milligram per deciliter. We could use that too. Fresh frozen plasma for congenital factor deficiencies and warfarin here overdose. So this is one of the emergencies. If warfarin overdose is used, we can use fresh frozen plasma, or here TCP, for example, thrombocytic here cytopenic purpura, or the C1 inhibitor deficiency, then we could here use the fresh frozen plasma for that. And finally, here if the number of platelets is more than 50,000 and the prothrombin time or the partial thromboplastin time is more than 1.5 the normal time. So it's so important to know that you should never use fresh frozen plasma as an expander because of infection. So we could use normal saline or glucose saline. This is a rule of thumb here. Never ever use the plasma as an expander. Remember that.